अच्छा जी, बिस्मिल्लाहिर्रहमानिर्रहीम। हम स्टार्ट करने लगे हैं आज का ग्रैंड राउंड। थोड़ा सा मैं बैकग्राउंड दूंगा इस ग्रैंड राउंड का। मारूफ में ग्रैंड राउंड्स होते हुए 5 साल हो गए हैं और पहला ग्रैंड राउंड जो था वो जुलाई 2019 में हुआ था और पहला ग्रैंड राउंड मैंने दिया था और पहले ग्रैंड राउंड का टॉपिक भी यही था। तो आई वांटेड टू रीविजिट दिस टॉपिक बिकॉज इट सीम्स लाइक कि अभी भी बहुत से लोगों को स्ट्रोक का नहीं पता और ये नहीं पता कि व्हाट आर द बेसिक थिंग्स जो कि एक्यूट स्ट्रोक की ट्रीटमेंट के लिए सबको पता होनी चाहिए। ठीक है, सो विद दिस आई विल स्टार्ट विद माय फर्स्ट स्लाइड व्हिच इज एक्चुअली फ्रॉम 5 years ago. दिस वाज माय फर्स्ट स्लाइड और आप देखें उसके नीचे लिखा हुआ है जुलाई 2019। ठीक है, दिस वाज व्हेन मारूफ वाज नॉट अ स्ट्रोक सेंटर. We were trying hard to make it a stroke center. TPA was not available. It was only available in black. And all we wanted was to serve our patients with the standard of care, which is up to par with the international standards. But we were not able to. But still, we tried for a few years back and forth, going to DRAP, Dr. Wahid and Harun Saab and myself. We used to go to DRAP various visits and try to get this, TPA approved so that we can get started. It still took 2 years, but eventually we got started. So this is from 2019, our first grand round. A little bit of intro about myself. I graduated from Shifa College of Medicine, and then I went to Wayne State University, and then University of Michigan, and then I'm back in Pakistan at Maroof. Then I was certified in neurocritical care as well as American Board of Neurology. So basic schema of brain is that this is brain. Let's see if I can use a. So this is brain, and if we zoom, this is the surface of the brain called cortex. If we do a histopathological section of it, you see this thing, this pinkish, dark pinkish, and then there's a lighter pink. Anything that is above this is cortex. If we zoom it further, you can see that it has different layers of neurons, and each neuron has different branches that connects it to the neighboring neuron. And so this is called a synapse. Okay, a synapse is a chemical connection between two neurons. They can be adjacent to each other or they can be far apart. To understand a basic neuronal circuit, for example, if this is, I'm sorry, if this is neuron 1 and neuron 2 and neuron 3, neuron 1 can have a direct connection with neuron 2 and release some chemicals here, and neuron 2 can have direct connection with neuron 1, like a reciprocal connection, and release some chemicals here, neurotransmitters. And then neuron 3 can both influence both of their connections independently. And so this simple circuit, which only includes three neurons, can have more than 300 functions. So just 3 neurons. Okay, and so as an example, one function, as a simple function, could be a memory. For example, memory of knowing someone. A memory of knowing someone would only be in the form of circulating current. So if something is flowing in this circuit, you might say, oh, I remember this person's face. So this is how brain works, So movement of you can say ions in a circuit is how memories or different functions of the body are performed. And it's not just this, there are downstream intracellular processes through second messenger system which can further impact it, and the functions can go into thousands, even in 3 simple neurons. So giving you an idea of how complex even the smallest of neuronal circuitry can be. So see, so we're talking about something right here. So 3 neurons connecting to each other here, and then they send axons, and these axons go all the way down to different parts of the body. Some go to the face, some go to the arms, some to different parts of the viscera, and then legs and stuff. And so there's the right side of the brain and left side of the brain. This these are different ways to see different tracts. This is called diffusion tractography. Anyway, just to give the basic anatomy. This is the same exercise I did 5 years ago. So I would like you all to raise your hands. And now you have to hold your breath. And whoever is done holding their breath, cannot hold anymore, has to put their hand down. Okay, ready? 1, 2, 3, go. चीटिंग नहीं करनी. वो उधर पीछे हाथ नीचे हो गए हैं कार्डियोलॉजी में. वापस ऊपर नहीं कर सकते, नीचे कर. 30 seconds, 35 seconds. So, एक रह गया. सांस तो नहीं ले रहा. So, you could not hold your breath for more than a minute. Okay. Now, why is that so? Because the mixed oxygen in the blood is being utilized by different parts of the body, including the brain, including the heart, and so forth. And so the amount of oxygen saturation in the blood is going down, right? And so you could not hold it anymore. And so the brain signaled you to start breathing, and that's why you put your hand down, right? So imagine this amount of oxygen the brain is deprived of for more than a minute. Well, for more than a minute, nothing really happens. If it goes beyond 4 minutes, reversible damage starts to happen. And after a certain point, irreversible damage can start to happen. We'll talk about that in a little bit. So we'll talk about these different things. We'll go ahead. Definition of stroke. Stroke is a sudden cessation of oxygen and nutrients to the brain tissue. It can be an ischemic stroke or it can be a hemorrhagic stroke. Both lead to downstream effects, lack of oxygen, lack of nutrients. So every 60 seconds, 2 million neurons die. 7 miles or 11 kilometers of nerve fiber is lost. And 16 billion synapses are destroyed every minute. In brain, there are over 100 trillion synapses, but every minute, 16 billion synapses can be destroyed. Hypertension is one of the main. 3 big things are hypertension, diabetes, and high cholesterol. Sorry? Particularly in the brain. In the brain, again, hypertension, diabetes is one of the biggest one, and high cholesterol, because eventually it causes intracranial atherosclerosis, and that leads to has a potential of breaking up when the blood pressure fluctuates. So I will come to that. Mm-hmm. Yeah, absolutely, it can cause, because without atherosclerosis, there can be smaller level arteriosclerosis that can cause lacunar strokes. So atherosclerosis has to have plaque inside the blood vessel wall, but arteriosclerosis does not. So it involves the smaller blood vessels. Usually with that, the strokes are of smaller, tiny, less than 1.5 centimeter size. But yes, independently, hypertension can cause strokes. So the most important thing is sudden change in neurological examination. You don't need to do neurological examination. You can just say कि फलां बंदा पेशेंट बिल्कुल ठीक था और suddenly एकदम change हो गया. All you need to do is notice that sudden change has happened. That sudden change can be inability to talk, inability to use a limb, numbness of one side of face or body, inability to maintain balance, inability to understand. Oftentimes, patients can have Wernicke's aphasia, and all that the family can think of is that suddenly उनकी memory खत्म हो गई है. So this is how they present the patient के ये मेरे वालिद साहब हैं, ये बिल्कुल ठीक थे और एकदम इनकी memory खत्म हो गई. So that can be a Wernicke's aphasia that they are actually presenting with. But the bottom line is that it has to be sudden in onset. And so clear difference from baseline. And then, of course, the comorbids are present in the history. And they may not be present. For example, if somebody is coming in with no medical history and they have an occult atrial fibrillation, you might not find any medical history correlating with that. The worst thing that one can do in an emergency room is to diagnose somebody with anxiety. This is the worst thing that a neurologist can do. If somebody comes in and you're saying, oh, ye to anxiety hai, and then ignore a big stroke or something significant, that's the worst thing that a neurologist can do. So nothing, we don't do this in the ER unless we're very sure. And then this comes physical examination. So there are different scores that can be done. FAST is the most commonly used score. And then there is Rosier score in the ER, and then NIH scale that is done by nurses, ER medical staff, neurologists. The most widely accepted score is NIHSS in the ER, and the most widely accepted for EMTs, emergency medical technicians, is FAST. So EMT does it, ER does Rosier or maybe FAST, and I do NIHSS. This is an old picture. This is updated picture. So FAST stands for face, arm, speech, and time. Face is if you notice any drooping of face, left or right, whatever. Arm, you can ask the patient, your loved one, to hold their arms up and close their eyes for 10 seconds. If you see one arm is drifting or they're not even able to hold one arm, then this means they're weak on that side. Similarly, you can do the same thing with the legs. Ask them to raise one leg for 5 seconds, the other leg for 5 seconds. In fact, this is how the stroke scale is done. In speech, ask them to say something, talk to you, and if you clearly see that they are unable to talk, they're slurring their words, then their speech is abnormal. Time. When you notice all these things, this hardly takes less than 2 minutes. Time is of essence. You need to rush them to the emergency room so that they can get the treatment on time. And then there can be multiple other stroke scales, different kinds of scales, but this is the most widely used. 1 point, so this is a Rosier. I won't go into detail. An NIH stroke scale, the most widely used and accepted. It has 13 items. It tests the language, it tests the motor movement, sensory sensations, visual fields, extraocular movements, dysarthria, aphasia. It does not check for posterior circulation. It's not a good representative posterior circulation as well as the anterior circulation. And by that, I will come to that later. What does anterior circulation and posterior circulation mean? But no score can replace a comprehensive neurological examination. This by far trumps everything. So right side of the brain and left side of the brain. I have, the brain can be divided into front of the brain, the blue part, the back of the brain, the side of the brain, and the rear, or the really back part of the brain, middle part of the brain. So front is mostly motor of the hand, motor of the mouth, motor of the face, motor of the leg. Everything that moves is from the front. Swallowing is from the front. Speech is from the front. So if you're not able to talk, if you have become mute, that means it's coming from the front of the brain. Red part is for understanding or sensation of the limbs, sensation of understanding speech, sensation of touch, and so forth. This is a complex thinking area, temporal lobe, and yellow is the occipital cortex for vision. Some big strokes which involve the red part also involve the the occipital cortex and can cause visual problems. And brain imaging. So you have a history that suggests stroke, you have examination that confirms it, and then you have a brain imaging. All you need to do is a CT scan. So is this a normal CT scan or abnormal CT scan? This is a normal CT scan. You can see a couple of things. You can see that this is the ventricle, anterior horn of the lateral ventricle. This is the posterior horn of the lateral ventricle. This part is the thalamus. This is putamen. This is head of caudate. These dark areas are white matter. You can see that white matters are going like this. This is how normal gray-white matter differentiation looks like. Anything that blurs this differentiation means that there could be a stroke there. But on this scan, I don't see any blurring. So this is a normal looking CT scan. What is this? Intracranial bleed. It's actually right thalamic bleed, most commonly seen in hypertensive bleeds. What is this? Subarachnoid hemorrhage. It's in subarachnoid space. You can see that this is the space where the blood vessel, the MC, is usually go, but it lies in the subarachnoid space. This is subarachnoid space. This is around the midbrain. This is subarachnoid space. So this is subarachnoid hemorrhage. So anything bright on the scan besides the bone, you have to think about bleed. This is the hyperdense left middle cerebral artery. Why is it hyperdense? Because the blood is not flowing in it. And when the blood is not flowing, the blood has calcium and other metals like iron, and so it gives a higher signal than the rest of the surrounding brain. So hyperdense left MCA suggests that there is a clot there. Similarly, you see that you can see a good gray-white matter differentiation on the right side, or on the left, this gray-white matter differentiation is lost. So means that there is a left frontal stroke here. These are subtle findings, but very significant. This is how MRI looks: T1, T2, flare, diffusion weighted imaging, and ADC. So ADC and diffusion weighted imaging, these two are what we use for acute stroke. Should look bright in this diffusion and dark in the ADC. So MRI takes time. MRI takes about 30 minutes for a full MRI, 30-40 minutes, and about 10 minutes for a acute stroke MRI, which includes DWI and flare. 1, 2, 3. So acute stroke MRI involves these three. But point is, you don't need an MRI to treat a patient with acute stroke. You just need a CT. So clear history and new onset symptoms, yes. Exam shows evidence of the same, yes. CT head is normal, yes. Treat as soon as possible. This is what we do. So acute stroke, last known well, should be less than 4.5 hours. So if somebody has stroke symptoms that started at 12 p.m., they should be treated within 4.5 hours. That's 4:30 p.m. All you need is CT head, and of course a few more things. I'll go over that. Normal looking CT, you give TPA. Besides TPA, the world is using TNK, which is tenecteplase and reticlase, but in Pakistan we only have TPA. I will go through difference. Not go to details, but a basic understanding is that the clot is composed of platelets, and the platelets can be like bricks, and the mortar or the cement can be like the clotting fibrin cascade, fibrin. And so if you have to break up a clot, you have to break up this mortar or the cement between the platelets. And this is what the TPA does. Doesn't do anything to the platelets. So when this breaks, the platelets fall apart and the clot breaks up. And so treatment, of course, depends on the cause. What is the cause of a stroke? That's why we do the stroke workup. The history of evidence is that in NINDS trial 1995 is the one which we still use to date and give TPA based on. It was in 1995, and we got TPA just 2 years back. 4.5 hours was, the time was extended to 4.5 hours through ECAS-3 trial in 2008. And more recently, if you have CT perfusion and it shows penumbra, you can still treat it within 9 hours from the extend trial. But if patient is outside of this window, all you can do is secondary prophylaxis, which means the damage is done. You cannot reverse it. All you can do is prevent another stroke from happening, which should not be the case. What about heparin and streptokinase? I still see a lot of young doctors asking this question: why cannot we use heparin, streptokinase? So heparin is mostly used for venous clots, where the flow of the blood is not that high, and it's more. If you look at pathology, it's more platelet and red blood cell rich clot rather than fibrin rich clot. So heparin works better in that. Streptokinase, for the same reason, there have been trials in the past which did not prove that TPA was superior to. It led to more bleeding. So then the TPA came. TIA. TIA is that when the symptoms of stroke come and then resolve by itself. This is actually as important as a stroke because this is a warning that a new stroke can happen. So if somebody has a TIA or TIA-like symptom, they should be admitted to the hospital. Why? Because if they don't, then there's a that they go home and they can have a stroke. Of course, if they can come back, that's another thing. But we, as a standard of care, don't take chance. We encourage them to get admitted and get a full stroke workup as soon as possible, so that we find the cause of TIA and treat it. The team, ER team, comprises of all of these: nurses, physicians, radiology, lab, neurologists, pharmacists, intensivists, rehab. Well, this come later, but first thing is this acute phase. Workup. The standard workup for stroke is you have to find out the most common causes. Cholesterol, you'd have to do fasting lipid profile. Diabetes, you have to do HbA1c. You have to check for blood vessels. Start with the heart, do an echo, ECG, check the blood vessels of the neck, and then so forth. And then, of course, the MRI, because some of the things you cannot assess without doing MRI. For example, if a patient comes and they're showing a stroke on the right and the left side of stroke, they either have an abnormal circle of Willis or they have a stroke that came from the arch of aorta or the heart. So now you know that you have to focus where. Prevention of stroke. The most important thing, I cannot stress this more, is hypertension, diabetes, hyperlipidemia. These are the, and of course, smoking. These four are the, well, physical activity is becoming the major contributor these days. So I would say 1, 2, 4, 5, and 6. These are the major ones. Of course, if there's a known heart disease or atrial fibrillation, you have to go for it. And obesity is gradually becoming a pandemic here as well. So for large artery atherosclerosis, and there are different trials on it. They can be, large artery, small vessel stroke, and so forth. It's mostly driven on stroke scale, and for TIA, ABCD2 score. The point is that if the patient has an NIH stroke scale of 4 or less or low, they're given dual antiplatelets, like Loprin or Clopidogrel, for 21 days or for three months, based on point and chance trial, which was done in China. But the most commonly accepted is a loading dose of 300 of 600 milligrams, depending on which trial are you looking at, and followed by 3 weeks of double antiplatelets, followed by a single antiplatelet for life. Most patients think that the medicine given is as a course, taken for 1 month, 2 months. No. Once you have a stroke, your medicine is for life. 2 medicines are for life: antiplatelet and statin. 20 to 30% of ischemic strokes are cardioembolic. Cardioembolic means it is generated by the heart and it travels up to the brain. When the blood vessels come out of the heart, the first blood vessels that go anywhere is to brain. Of course, the heart supplies itself first, but then that direct flow, you can say, is directly into the brain, the internal carotid or the common carotid. And therefore, if there's a cardioembolic phenomenon, it has more chances of going in brain than anywhere else, like a limb, or upper limb, or lower limb, or gut, and so forth. So this is driven by MRI. So you do an MRI, you see cardioembolic stroke picture, and you look for AFib or heart, illness. Of course, you have to look for this, do these scores, CHAS, VAS, NHAS, blood, and come up with the, if the AFib is confirmed, to come up with what you need to give. For example, CHAS score more than 2, give anticoagulant. As blood score is to see how likely are they to bleed after this anticoagulation. So a lot of thought process goes into deciding what you need to give and how you need to give them. Antiplatelet therapy, like I said, dual antiplatelet therapy for 21 days or 90 days, depending on point or chance trial. Most widely accepted is 21 days of antiplatelet therapy. If somebody is allergic to, for example, aspirin, you can use other platelet inhibitors, dipyridamole and glycoprotein 2b3 inhibitors, efzofitimab, and so forth. So Maru Stroke Center, this was my slide when we did not have Stroke Center. I wrote there is aim to build a primary stroke center capable of administering TPA and managing patients with acute stroke. I wrote down the components, and I also wrote down that I am currently doing teaching sessions in the ER and many other places, and then mock course. And then full-fledged launch was planned in 2019. And guess what? We started our first TPA was in February 2022. This is my message to Dr. Wahid in February 2022 when we had the first TPA. 2.5 hours of ER stay was worth it because the patient came with complete mutism and started talking. So now we're treating patients with acute stroke within 4.5 windows since February 2022. We are referring large vessel occlusion for thrombectomy to appropriate nearby centers. For example, if a patient comes and you give them TPA, there is a 33% chance that it is going to open the blood vessel, but there's a 66% chance that it will not. So we don't take chances. If we give TPA, like 2 days ago, I gave a patient a TPA and like bolus, and then infusion was completed inside the ambulance, and the patient was transferred for thrombectomy. They underwent thrombectomy, very good outcome. With TNK, you can just give one-time bolus. They don't need to have an infusion. So we have Maruf has a relative catchment area because most of the patients first go to the nearby bigger hospital, government hospital. So we have treated 20 patients, TPA patients. Of course, we have had so many more. There might be 200, 300 stroke patients that come in a year, but only certain percentage are eligible. So we have treated 20 patients with TPA. Average TPA candidate is once in every 2 months. We always have a power level of 2 TPAs present at all times so that we don't run out. Last patient was 13 August, which dense left MCS stroke treated within 64 minutes of ER arrival. Actually, our ER door to needle time was much better than this. This would be an outlier, basically. So our average door to needle time is 44.35 minutes, which is much better than international recommended standards, which is less than 60 minutes. We have the best door to needle time of Pakistan, which is 11 minutes. Before that, the title was held by our nearby hospital, 16 minutes. And this happened in January 2024. Stroke centers in Twin Cities. In Islamabad, there are only two stroke centers, Maruf International Hospital. Maruf is a primary stroke center. Shifa is a comprehensive stroke center. But besides thrombectomy services, we have everything here. Like we have rehab, so we are short of comprehensive stroke center. We have neurosurgery backup. For Rawalpindi, we have Pak Emirates Military Hospital, which is a comprehensive stroke cancer center, and Fauji Foundation, which is a primary stroke center. We have other hospitals like Rawalpindi Institute of Cardiology. They don't have the TPA, or sometimes they don't have the neurologist. So it's a little bit unreliable, but they are also a stroke center. So this was the picture, the last slide that I put in 2019, where we were in the tunnel and we were looking for a bright future. And now we are outside of this tunnel and we are giving TPA. Thank you. You guys have any?
The audience.
Not to mention the opisthotonus that projector is having.
As I mentioned, but also I think that
Yeah.
That is being more ready and more by the guiding point of view, the body, which is that for the heart disease, most of the large kind of very dense and each other.
Right.
We couldn't stop because, given that cardiologist walks in patient in mind that the first patient can be at that school or we should be.
Yeah.
Is there any contraindication?
There can be many contraindications to TPA. There's a whole list. TPA for stroke. Yeah. The first and foremost is if there's a bleed, of course. But if the patient comes into the emergency room, the few things that we check is what's their blood sugar and what's their blood pressure. So if their blood sugar is less than 50, we don't give TPA. That's a contraindication. We give blood sugar because that reverses neurological symptoms. If their sugar is more than 400, we don't give TPA. Either we bring it down with insulin and then give TPA, or we just when we bring it down with insulin, the symptoms can resolve with that. So these are two. 3 is INR of 1.7 or more. Even if the patient is taking warfarin, we still check INR because if they're taking warfarin and INR is less than 1.7, we will still give TPA. And then there can be several other, like history of colon cancer is a contraindication. Surgery within the last major surgery within the last 3 months. Surgery at a non-compressible site within the last 3 months. If it's a compressible site, you can talk to the surgeon and still give TPA. GI bleed in the last 3 weeks. Urinary bleed in the last 3 weeks. Any history of brain bleed in the past, even if it's right. So basically what you have to do is this, you cannot just do these couple of things and then give TPA. You have to go through during the history process. That's what we do. We go through the whole list. We talk to them, koi bleeding to nahi hui urine mein, koi stool mein to nahi hui, quickly. It hardly takes 1 minute and then we give TPA.
15 minutes or 60 minutes. How do you check this beat in the brain in that time?
So as soon as the CT scan is done, I'm usually present in the CT room console and I look at it myself right away. Don't wait for the radiologist because they have other things pending. They can read it very quickly actually, but I don't wait for that. CT. First thing is ABC, blood sugar, blood pressure, right away. And in the meantime, we keep taking history and examination. Patient is being rolled and we're taking history, we're examining. And then while the patient is in CT scan, we're sitting there waiting for CT. As soon as CT is done, look at the images. That's it, decision is made.
Then you continue with one antiplatelet. What would that?
It can either be any of that. So if you start a patient on aspirin and clopidogrel, you can continue any of them, either aspirin or clopidogrel. Doesn't matter. What is NOx? Oh, okay. No, X. Novel oral anticoagulants. Novel oral anticoagulants are not tested in acute stroke setting. They are tested as a preventative strategy for cardioembolic strokes only.
Difference between comprehensive and primary.
So primary stroke center gives basic stroke treatment, which is assessing patient given TPA, and post TPA admission, they have the surgery backup. The comprehensive stroke center also has interventional neuroradiology capabilities and generally more complex cases. So I think thrombectomy is the one, if you add it, it becomes a comprehensive stroke center. You can use a mic.
The patient is diagnosed as suspected stroke. If not, they will get control from even start delivering because we know that because the
For stroke patients, heparin is not the treatment for acute stroke. This is exactly why I wrote that. Heparin is never used as an acute treatment. But after 48 hours of giving TPA, you can start the patients on, actually after 24 hours, you can start the patient on aspirin and you can start them on Clexane for DVD prophylaxis. Mhm.
What related from mind like 40,000, 50,000, 1 lakh.
As a general rule, this does not pertain to neurology. This is basically medicine. So if the patients, you look at the trend, if you give Clexane or heparin and you see that every day platelets are falling, you stop it, even if the platelets are more than 100,000, right? But if it's less than 100,000, you become more careful. You have to prove that the patient's platelets are falling because of heparin-induced thrombocytopenia. You either do antibodies, or you prove it that when you stop it, platelets go up, and you start it again, platelets go down. Then you have proven it that the platelets are falling because of HIT. So there is no threshold for that. Of course, all the time. That can happen with that as well. Right, but these are long-term effects, but this is digression from today's talk. So let's stick to the talk. Heparin, we're talking about acute stroke. We don't use heparin in acute stroke. Okay, as a prevention, you can use it after 24 hours of giving TPA. Okay, any other questions? No, there was actually in 2019 when I was doing all these these sessions, educational sessions. I was also doing it in some other government hospital with the plan of doing a head-to-head comparison of TPA and streptokinase. But then COVID came and everything, stopped.
Question is about the for how long can we this time limit for EPA, the time limit for
Right.
and which patient will go for thrombectomy, their size of the vessel, suggest that it takes another vessel.
Excellent question. So thrombectomies are usually done for anterior circulation. Anterior circulation means the sclerotids that go and then from the anterior cerebral artery and the middle cerebral artery, and the vertebrals that go from the back on the the ICA, the posterior cerebral arteries. Okay? Thrombectomies are usually done for anterior circulation. It can involve the major M1, which is major middle cerebral artery, or its first two branches, which are called M2. So M1 and M2 are the ones where we do thrombectomies. Similarly, some patients, some experts can go into A1, A2 as well. And then posterior cerebral circulation, the mostly done or the easily done, most easily done thrombectomy is of the basilar artery, which is the major, major artery that is made by forming two vertebrals. So thrombectomy is done for these major blood vessels. Time. So time is usually up to 12 hours, but more recent studies can be up to 24 hours. It all depends on the collateral circulation. For example, if somebody comes in, they are 6 hours out of window, and you do their perfusion scan, and it is still showing penumbra rather than core infarct, then you know that this is a salvageable part of the brain, and you can still go for thrombectomy. So if somebody is lucky and they have so much collateral circulation, they can survive the stroke for 24 hours. And somebody with little collateral circulation may develop swelling and brain edema within a few hours, even before the 4.5 hours. Thrombectomies are done in Shifa and in MH. They have the team. They have the whole team. They're also training new people, mostly army personnel. No, they are neurology trained, and they are neurointerventional neurologists. But at Shifa, so there are different kinds of catheters that they use. Aspiration catheters, retrieval catheters. The retrieval catheter, what they do is they go beyond the clot, open the catheter, and pull the clot. So when it's coming back, it's pulling the clot with them. Aspiration is they go closer to the clot and they allow minor suction, and that sucks the clot. Oh, intra-arterial. Yeah, right. So a lot of doctors do that, intra-arterial thrombolysis. So while they're giving while they're near the clot, they give TPA, but it has led to more bleeds than simple thrombectomies. Yes, sir. But they don't have a dedicated neurologist. They have interventional cardiologists doing thrombectomies, but they don't have a stroke certified neurologist there. Yeah.
It's not reliable.
Yeah.
No.
Yeah. So they can. Why I took the name of all the other institutes, because I trust them and I rely on them. So if somebody comes in and if they're closer to Fuji Foundation, I would say go to their Fuji Foundation. Don't come here, because that's the closest to them. But that's why I did not put RIC there, because of the same reason.
Thank you very much.
Thank you. Thank you. You done, Kavin?